Good morning, good afternoon, and good evening, everybody. Uh, this is a pleasure to having you all back, and we have yet three very fascinating sessions for today. Without further ado, I'll introduce my colleague, my brother, my friend, Dr. Ayman Rahmani. He will take over the proceeding today, and he will also summarize what happened last 2 days. Dr. Ayman, you are there? It's
Yeah,
over
good
to you.
afternoon, everybody. Good afternoon, all the colleagues who are joining us today for the first day, and welcome back to all our participants who stayed with us in the last 2 days. We have an exciting program coming your way today, as you witnessed yesterday and the day before. I would like to summarize what we learned yesterday from our expert panel and expert speakers. Yesterday, we started our day with the delivery room management of babies and oxygen use in the delivery room. Then we moved along to surfactant therapy, innovative techniques. Also, we learned about new innovative process of having high frequency oscillation as a protective strategy for premature infants. And we end up the day yesterday with the quality session, how to reduce infection in the NICU and reducing antibiotics use. And we ended the day with exciting presentation from Professor Alan Lucas about preterm nutrition, first to no harm. So today we have, as Dr. Junaid mentioned, we have an exciting program to end up the this year conference. But before we start this, I would like to announce that we actually reached a record number yesterday of participants, of 1,322 participants logged on live yesterday to listen to our expert panel. We have 15 international speakers from 6 different international countries that shared with us their wealth of knowledge and their experience. So I would like to welcome everybody, and I will hope that we will keep it as we done yesterday, as much interactive as possible. And I will hope that everybody benefits from today's lectures. Welcome to a third day, and we'll start with the first session.
Okay, so Ayman.
So we will start the first session. Welcome back, everybody. So it's given me immense pleasure and honor to introduce the first speaker of this session, my colleague and dear friend, Dr. Hussam Abu Adma. He is joining us from Saudi Arabia. He's the head of clinical transformation and quality office in Medina Cardiac Center in Medina, Kingdom, Saudi Arabia. He is have background of biomedical informatics, a certified professional healthcare quality, CPHQ, Six Sigma, and he has a background of neonatology as well as neonatal resuscitation and health care accreditation. He's gonna add to us for first time in our conferences a flavor of informatics, healthcare informatics, and how to utilize this in the field of neonatology. Please join me. Welcome Dr. Hussam Abad.
All right. So, Bismillahirrahmanirrahim. Salatu wassalam ala ashrafil mursaleen. Thank you so much, Dr. Ayman, for the introduction. I'm very privileged to and I'm very grateful for you and the organizing committee to invite me today to talk about the health informatics and neonatology. So my favorite topic, my favorite experience, and passed through and worked together in Durham Hospital. This is a fascinating experience I ever had. So thank you. Today again, I'd like to go through some of the introductory session, I would say, exactly like you addressed, Dr. Ayman, for the health informatics in general and especially in neonatology. So by this, it's not easy to compile all together in 30 minutes talk. However, I made sure that in our agenda today, we need to explain what health informatics, identify reasons why to transform and use electronic health records, and to clarify the importance of the quality data and to explore some of the potential benefits of health informatics in neonatology. So health informatics is the integration of the health information technology along with the health information management. To this end, so health information technology makes the tool we use as professionals to handle the information using computers, hardware, software, networking, programming, etc. And the health information management, which is a big and huge department in healthcare organization nowadays. And it's meant to deal with records, coding, documentation, clinical documentation, etc. These kind of things. So health informatics is that integration and the application of technology tools and information systems in a healthcare setting or context. Another definition is the acquisition, storage, retrieval, and use of healthcare information to foster better collaboration among a patient's various healthcare providers. Health informatics plays a critical role in the push towards the healthcare reform. Health informatics is an evolving specialization that links information technology, communication, and healthcare to improve the quality and safety of our tiny angels and patient care in general. Another definition is the integration of the healthcare science, computer science, and information science, and cognitive science to assist in the management of healthcare information. This is by Sabine McCormick in 2015. So with subsets for medical informatics, nursing, pharmacy, etc., a couple of them in there. The definition I like is it's not that I like it's used by Professor William Hirsch. He's one of my professors in this field, and he's the head of medical informatics or biomedical informatics in the Oregon Health Science University. And his definition is biomedical and health informatics is the field concerned with the optimal use of information often by technology to improve individual health, healthcare, public health, biomedical research, etc. And hence the informatics applied in a more focused, as we mentioned, so it's medical, nursing, dental, etc. So we opted as professionals to seek structured data and through a digital healthcare environment. So using electronic health records, and I want please you to think from now on about think data in your native service. So data is the whole key. The key is data in whatever service. So think from now on only neonatal service and data. So question for you, and I need to have that answer probably at the end or at the discussion. So what's the best system to adopt? We need to have to implement electronic health records, and healthcare organizations across the globe, they range between paper-based environment towards fully electronic, and this needs another definition, what fully electronic means. And most or some of the healthcare organizations at the moment, they are in hybrid practice environment that's mix of paper and electronic. Now, as mentioned earlier, the full electronic needs a definition. What does it mean? However, the question is still valid. What's the best system to adopt in any healthcare organization and setting? So keep that in mind as we proceed further. You need to have your understanding what that best system means. So with the painful experience we all had, those files and papers, and so one of the studies up to the information missing during patient visits. See the numbers and the percentage of lab results missing, the letters, dictations, radiology results, etc. This is quite risky, and luckily we have experienced the transition from paper-based environments towards the electronic. Excuse me. So with paper files, again, the legible handwriting and the questions are still valid. With paper files, are they accessible, complete, quality of information? What sort of quality, any standardization? And here at this end, I'd like to thank Dr. Ayman, because during our working with the paper-based environment, he was very much pro the standardization of our approach and documentation, clinical documentation. So, and the paper files, are they useful information? Is they whatever written there is useful or not? Are they retrievable? Are searchable? Available? What? So, of course, we know the answers that we challenge. This was a huge challenge. For here, we'd like to why to transform. We need to know why we need to transform. I was privileged to work on the healthcare transformation project in Nova Scotia in Canada. This is home, and we call that one person, one record. And I was assigned as the physician advisor, physician lead, to identify from a business perspective why we need to transform. And I had listed these 6 drivers why to transform. We call that targeted benefits. So the first was enhance patient safety. So we need to think about our patients, and the first would be enhance patient safety. Second, improve the quality of the clinical outcomes. So back to the safety point, 60% reduction was experienced with a couple, actually not one, where healthcare organizations and contributed into 60% reduction in serious medication errors because of the readily available evidence-based practice guidelines, readily available online, and alerts to alert practitioners for any point regarding, for example, ordering and maybe ordering medications, etc. So the second is the improvement of quality and clinical outcomes, and so it's improved compliance with accreditation in Canada standards called the ROPs, or required organizational practices, and preventable and respiratory events, management and adverse events. The third driver is the improved patient experience and satisfaction because of the timely and faster decisions on patient care. This has participated in huge reduction in repeat testing and shortened turnaround time and wait time, and eventually shorter length of stay in hospital. Fourth driver was to improve the access to health information to providers. So having the information is readily available for the right clinician at the right time, regardless of location. The fifth driver is the health system use of information, and this is the whole thing today is talking about this point, about the health system use of information, and in alignment with the Canadian Institute for Health Information Vision 2011. The sixth driver, and I meant to make it the sixth and last, is the optimized expenditure, because hospital information system is not meant to save money, however, is to optimize expenditures and to redirect to improve health system. So this was meant to reflect the use of health information according to the Canadian Institute of Health Information, CIHI, Vision 2011. So primarily the health information, we provide the data as healthcare providers here at the bottom. So healthcare providers, we feed the systems with data, and these data primarily in use for the primary healthcare, primarily in healthcare and direct patient care. However, still the other use of the health information towards clinical program management, health system management, population health and research, etc. We need to keep that in mind, because now talking neonatology, clinical program management or service line management, again, we have a lot of data, and we'll explore this as we go further. Targeted benefits. So the targeted benefits, this has to be set first place before adopting a system, or even afterwards, though difficult little bit. So these would be at the organizational, facility, domain, service level. The stratified design, the benefits would lead to the discussion and agreement around related standardization, activities and efforts, along with definitions. So standardization is a way to standardize the approach, practice, and use of tools to yield comparable and usable data. And I need your thoughts here around customization and variability. So during the implementation of the hospital information system, a common question comes is, no, you know, at our facility, we need to customize the system to accommodate our needs, as we are special, different than the other facility within the same organization. We need to give this a big thought, because the more customization, the more availability, and think about data. This was I created to explore or make it to simplify the understanding of the integrated system, and so it's the patient centric. So it's integrated, all needed modules in here. And this depends on the organization and the specialization, different facilities, what modules need to be implemented, etc. However, at the end, it's integrated health information system across the organization, and it's patient-centric. Now, think about if it's not integrated, and different modules, different vendors, and what would happen with the interoperability, which is a very big challenge for the quality of data and the integration and the flow of information between different modules. So this, of course, would be under the umbrella of privacy or HIPAA and accountability frameworks. So system users, you can imagine the amount of data generated each day practicing and using a health information systems and different modules, different entries in back offices, in clinical settings. So healthcare is an information intensive environment. You can imagine the amount of data generated every day. So with the patient journey and outpatient clinics and admissions, medical documentation, nursing documentation, machines generate a lot of data, lab, diagnostic imaging, pharmacy, etc. So all these data will will get to the data repository, where the output would be report. So we need to be very careful. Now, have you heard about DRIP syndrome? So DRIP syndrome is one of the syndromes we need to be very much aware of. It's data-rich, information-poor environment. Now, it's not a secret that it's not uncommon for healthcare organizations. They ended up having DRIP syndrome across the globe, and I came across many healthcare organizations where they implemented health and a hospital information system or health information system for 19 years or even more. And they couldn't make use of the rich data they have in their repository just lying in there of no use. So we need to be careful. So that paradigm is very valid. So garbage in, garbage out, I'm sorry for that, but it's for a fact we need to be much aware of it. So a garbage data with the perfect model as informatics along with the systems implemented, again, this yields garbage results. On the other way around, again, still with perfect data, so with all the standardization and all the committed users to follow the standardization, whatever, but with the bad or garbage model or system, again, garbage results. So we need to be very careful what we're doing in order to ensure the quality of data that's accurate, comparable, consistent, complete, retrieval, usable, reliable, updated, and relevant. So need to be careful. Keep thinking about data quality every day, every time you enter data for whatever. I like this, the pyramid about data, information, knowledge, wisdom, because data is just reflects the individual facts, figures, signals, measurements, etc. This would yield to information that's more organized, structured, categorized, useful, condensed, and calculated. This yields again to knowledge, which is a more mature idea, learning, notion, concepts, etc., and eventually to wisdom. The more we go up with the pyramid, the more maturation level within the organization to make use of the proper use of the health information system. So another question I need to have you to think about is transformation process is a vendor specific. This is very, very strategic. Is this vendor specific or vendor neutral? We need to keep these two questions: what's the best system, and is the transformation process is vendor specific? So healthcare and NICU. So a lot of efforts being invested now to work on machine learning techniques that have been used to develop models in hemodynamic care for newborn infants and ventilatory support, etc. So a lot of machines are available down there in NICU, syringe pumps, infusion pumps, monitors. So they will talk about this in a minute. But again, the machine learning techniques is the direction now, along with the big data and artificial intelligence in sort of predictability, disease prevention, surveillance, and screening programs, early identification, prevention, and early management, national health system management, and national international program management, and use of robots in healthcare. So hemodynamic support in neonatal intensive care is directed at maintaining cardiovascular well-being, as we all know. So monitoring those vital signs plays an essential important role in augmenting care in a reactive manner. By applying machine learning techniques, a model can be trained to learn patterns in time series data, allowing the detection of adverse outcomes before they become clinically apparent. This is very useful in NICU. So different machine learning techniques have been used to develop models in hemodynamic care for newborn babies. However, a lot of focus needs to be invested on their potential benefits and research the pitfalls and challenges related to the implementation in a clinical care setting. Kaiser Permanente has capitalized on its integrated system and applied big data analytics. Eventually, it's a module, analytics module to improving healthcare outcomes. So analyzing years of maternal and neonatal data to develop an algorithm to predict the likelihood of sepsis in newborns, which has helped in reducing unnecessarily use of antibiotics. So Simon was talking about yesterday's lecture about the use of antibiotics. So this would be reduced having algorithms and the big data analytics. So analyzing data from years of acute episodes to predict the likelihood of in-hospital deterioration, transfer to intensive care unit, these sort of analysis of data would lead to improving the outcome and improve bedside care. The translation bioinformatics approach are now biomedical knowledge, a new biomedical knowledge relevant to neonatal care. So incorporation of this new knowledge into clinical practice via integration within electronic health records would allow for prospective evaluation of its impact on patient outcomes and ultimately lead to the delivery of personalized precision medicine so that's diagnostic, prognostic, and therapeutic strategies precisely tailored to each patient requirement. This is very important. So neonatal informatics was examined as it pertains to topics such as comprised provider order entries. CPOE is one of the modules we use for ordering, and the clinical decision support, again, the CBS module, and handover communication, data entry in whatsoever for clinical documentation, nursing documentation, machines data, generated data. So all of them would contribute to this topic. So the goal was to illustrate a realistic vision for the future of neonatal informatics by citing examples in which translational bioinformatics are transforming patient care. So translational bioinformatics is the transformation of increasingly voluminous biomedical data and genomic data into proactive, predictive, preventive, and participatory health. These concepts are very interesting and have some overlap. So talking proactive care, acting in advance, so it's just a proactive thing. So acting in advance to deal with an expected change or difficulty. Earlier recognition of the patient's deterioration status allows the intervention that may alter the clinical course toward an improved outcome, like in neonatal sepsis, for example. The other concept is the predictive care, that to state or to make something known in advance, especially using inference or special knowledge. So patterns mined from clinical data would be useful for predicting diagnosis and outcomes. For example, research examining patterns in the clinical data that precede a diagnosis of necrotizing pericarditis. This is very useful as well. Preventive care, so preventing, hindering, etc. for prevention. For the implication here is the prevention of preterm births. So early contributions resulting from translational bioinformatics approaches include the identification of candidate serum biomarkers for earlier diagnosis of preeclampsia and identification of maternal environmental factors that may influence preterm birth. The last is participatory care, that the process during which individual groups get involved with the decision making and the program activity. And the example here, the electronic tool can be used to engage parents of infants in NICU to improve family satisfaction and may facilitate early discharge from the hospital. So I think at this, I would just conclude. I'm very cognizant about the time. The take-home messages are: you need to ensure the proper use of electronic health records, and talking about the targeted benefits at the organizational facility and the service line, or the service like neonatal service. And always remember data quality as providers and users for the electronic health records. Be aware of and sponsor the set and approved change within the organization, and be engaged and encourage others to do so. Follow standardization projects and whatever the targeted service, and many improvement potentials that are out there using health informatics in NICU. With that, I would conclude, and thank you so much.
Thank you very much, Dr. Hussam. Excellent presentation as usual. It's really, opened our eyes into how we can use data and informatics in improving our care for neonatology. Now, I would like to introduce the next speaker of this session, and we're going to stay in the realm of computer, but we're moving from using this technology from informatics to clinical care. It gives me great pleasure to introduce Dr. Anur Dayal. She's pediatric specialist at Children's National Health Hospital in Washington, D.C. And she's assistant professor in pediatrics at George Washington. She is a graduate of medical school in Ohio, and she did her residency at Cleveland Clinic, and she is American Board Certified in Pediatrics. She's going to be talking to us. I don't want to be giving all the excitement about her title. The title is the Baby Steps Technology, and I would like to welcome Dr. Anur Dayal.
Push holding slide, please, Sidan.
Okay, you can hear?
Yes, Dr. Anu, please just hold for a while. So now you can see the preview screen. Okay, Dr. Anu, you can start now.
Great, thank you so much. It's my honor to present at this neonatology conference on the hot topics of neonatal medicine. I really enjoyed the previous discussion today on translational bioinformatics. I am actually not a neonatologist, but I am a pediatrician, and I work with little tiny babies just after they're born as well. And I'd like to talk to you today about reimagining treatment for pediatric clubfoot, and it's a project which we affectionately call Baby Steps. My name is Anu Dayal. I am a pediatric hospitalist and an orthopedic hospitalist at Children's National Medical Center in Washington, D.C. I'm also assistant professor of pediatrics at George Washington University School of Medicine. Okay. There we go. And before I start, I wanted to thank the people of Abu Dhabi. They gave a really generous gift to Children's National in honor of His Highness Sheikh Zayed, through which my research has benefited. And this research builds on his vision to improve the health of children around the world. So thank you very much for making this vital work possible. So I'd like to talk to you about pediatric clubfoot. It's a three-dimensional deformity of the foot, which appears, at birth. It happens in utero for reasons that we don't know. And what happens is, as you can see in this picture here, the baby's foot is, instead of being straight like this, it is turned inward and upward. It's actually the most common skeletal deformity in children, and it has an incidence of 1 to 2 per 1,000 births. So the biomechanics of clubfoot, it's actually very interesting. So there's a problem with tendons, and then there's also a problem with the bones of the ankle and the foot. So some tendons in the foot are longer than normal, and some of them are shorter than normal. And that is what causes this upturning in a three-dimensional way. As you can see here, this is a very severe case of babies who are born with clubfoot. And as you can imagine, if it's not treated, they don't grow out of it. And these babies turn into toddlers, the toddlers turn into adults, and they end up walking on the outer edge of their foot, which is really sad. And if it's untreated in a lot of places, these children are marginalized around the world. So this is more, just more details on how we categorize the clubfoot. We talk about it in 5 different components. So one is the equinus deformity. The foot is pointing downward instead of at a 90 degrees. One of this is the varus component, where you can see the back of the leg and the ankle are not in the same direction. This is adductus, so the heel and the toes are not aligned. This is cavus, so as you can see here, the big toe is curled inward, and it's actually not in the same plane as the pinky toe. And then you have an element of derotation, where you can see, instead of the foot being straight, it's actually rotated in many different severities along the axis. And it's interesting because it is the most common skeletal deformity. And as I was doing my research, I learned that the Egyptians actually painted pictures of babies or even adults on the walls of the pyramid. And then the father of medicine, which is Hippocrates, the Hippocratic Oath, he actually wrote about a pediatric clubfoot and his treatment for it back in 400 BC. So the incident, as I mentioned, is 1 to 2 per 1,000 births. And so worldwide, it's about 250,000 new cases each year. And over 1 million children have not been treated, and they can't walk properly, and is the leading cause of physical disability in the world. There is a predominance in males, about a 2-to-1 ratio, and this is consistent across all ethnic groups. 80% of these are isolated birth defects, which means that there's nothing else wrong with the child. There's no other orthopedic problems, there's no heart problems, there's no lung problems. It's really isolated, and there's also no intellectual problems. And it has an idiopathic etiology. They've been a lot of gene research into it, but they haven't isolated anything yet. And sometimes 25% of the times there is a family history. And so again, this is what these children look like. If they're not treated, they grow up into adulthood like this. And I think the biggest thing for me is that this can be treated, and these children can grow into whatever they want. So this is a picture of Kristi Yamaguchi. She's, the very famous ice skater from the United States, an Olympic medal. I forget which Olympics, but she was actually born with bilateral clubfoot, so both her feet. And she was treated early in infancy. And the reason actually she started figure skating was to strengthen her legs, and then she became an Olympic ice skater. So I think that's pretty remarkable. So the current standard of care to treat clubfoot is actually called the Ponseti method. And it was developed by a surgeon in Iowa, Dr. Ponseti. And what he realized is that they used to do surgery for this, and doing surgery in a little baby, it really leads to a lot of scarring and problems later on. And so what he realized is that you can actually serial cast these infants. So what they do, as you can see here, it can take anywhere from 4 to 6 weeks, sometimes 7 or 8 weeks, depending how severe it is. Every week they apply a long leg cast all the way from the groin to the toes. And the orthopedic surgeon, in a very specific way, manipulates the club foot and turns it outwards and actually overcorrects it during the course of the treatment. So every week the baby comes in, they put on a new cast, they come back the next week, they take off the cast, manipulate the foot again. and so on and so forth. And using this method, it's actually 95% successful, which is amazing. So the question is, what is the problem and why am I interested in this research? So there's actually a lot of problems, or I should say difficulties with this method currently. Physician specificity, the process, and then the main ones are really access to care and medical education. So physician specificity, this isn't a normal cast that you can go to your emergency room or a general practice physician or the ER to get placed on the baby. It actually takes a lot of training and expertise by pediatric orthopedic surgeons who see many of these cases. And if it is attempted to be applied by someone who isn't as well versed in the training, you can actually worsen the deformity, which can lead to non-correction or need for surgery later on. In the United States, I'm sure as everywhere else, pediatric orthopedic surgeons are very talented, but there are not as many of them as we would like. In Washington, DC, we're surrounded by 4 states, and we have parents who drive to DC, you know, sometimes multiple hours, 3 to 4 hours a day for a one-way trip to an appointment, and then they drive home another 3 hours until the next week. And this is only exacerbated around the world where there's the distance is much larger. You know, babies with leg casts. So basically for 2 months while your baby's having this treatment, you can't bathe them from the waist down because they have plaster casts. As you know, you can't get plaster wet otherwise, especially with a baby's skin. It's very sensitive. It can lead to skin ulcers. Babies have, you know, their diapers, there's a lot of overflow. You don't want to get that on the cast as well. And then as we've seen in COVID-19, a lot of the Ponseti clinics have closed. And so parents are unable to either start their baby's treatment at ideally less than 2 months old, or they've had to interrupt their treatment. And then we use a cast saw to take off the cast, and you know, it makes a loud sound, but also pediatric skin is very sensitive and occasionally you can have cast saw burns. But this is the biggest problem with the Ponseti method right now. It's all over the United States. In Europe, they use a similar method, but a little different. But since 85% of the kids who are born with clubfoot are actually in low and middle income countries, there's no access to this care. And so they're growing up without any treatment. And then fourth, there's a component of difficulties in medical education. So as you can see, it is a 3-dimensional deformity, but as we describe it, and as we describe how flexible the foot is, we're actually scoring it on 2 dimensions, as you can see here. And reality, as we've seen, it's a 3-dimensional correction, and there isn't a way to predict how long the treatment will be or how responsive the child will be to treatment. And there's also no imaging used. So there's no x-rays. If you take an x-ray of a baby's foot, you know, their bones aren't ossified yet. We're not going to use CTs in little infants for radiation. And then MRIs are also very expensive and very bulky. So overall, the treatment of Ponseti method is very effective, but it's also very subjective. Orthopedic surgeons have a very trained method to do it, but it's very artisanal. It's very hard to teach. There's no images to share. There are no data libraries or data catalogs. And it really doesn't adequately talk about how the foot is changing in 3 dimensions. So the question is how we can make this better. The Ponseti method was introduced in the 1960s, and that was the same year that we landed on the moon. And there haven't been any advancements in that. And now we're in 2020 and we have 3D imaging and computer modeling that really can be leveraged to improve data sharing in medical education. So I've been reading a lot about biodesign statements. So this is going to be my biodesign statement for this problem. So what we're doing is we're looking for a way to measure the complex 3-dimensional movements in serial clubfoot casting for infants less than 2 months old with a diagnosis of clubfoot, in order to quantify the correction process and improve healthcare delivery. So in the current state, the baby comes in, we kind of eyeball it, we look at it, we score it in 2 dimensions, and then the orthopedic surgeon, you know, does their treatment. but we'd love to reimagine the care of how we're going to do this. And what we'd like is a future state where you can actually introduce imaging. So what if we could obtain a 3D image of the deformity and then use computer modeling to predict all the different next steps and stages, and use that to help democratize healthcare. So this is our team who's working on this. I'm the pediatrics lead. I'm working with the chief of orthopedic surgery at Children's, Dr. Achin, Dr. Cleary, who's a scientific director at Children's, and Dr. Monferretti, who's our biomechanical engineer and computer vision expert. So we're trying to develop a precise and accurate method to quantitatively measure the three-dimensional angles and spatial differences in serial clubfoot casts, and also simulate transformations in computer models. So we approach this with 3 different steps. One, we're trying to analyze the clubfoot in 3 dimensions. 2, we're trying to manipulate what would happen to the clubfoot during the treatment process. And then we're also trying to simulate a model and make it so it's precise and accurate and clinically equivalent to what an orthopedic surgeon would do. So this is some examples of what we've been working on. We have a very high volume Ponseti trained orthopedic surgeons, and we see a high volume of clubfoot patients. So we've been analyzing them and saving their casts through their Ponseti treatment, and then also noting what their DiMiglio score is here. So we know how flexible the foot is. So we can kind of determine what the different treatment process and treatment paths are for each patient. So this is a video of one single patient going through the casting technique. And as you can see, all the casts are overlined on top of each other. And you know, the thigh and the shin part, that stays the same. But if you look at the bottom, you can see the foot moving. And so this is an example of the trajectory that we've been analyzing in 3 dimensions. And then we introduced computer modeling. So this is some like rubber clubfoot models that are used for training. And what we did is we 3D scanned them and we tried to manipulate them to move in the direction for correction. So here are some examples of what it looks like. This is the before here in the dark, and then you can see where the foot has moved. And this is representing what the treatment path is for the infants. And this is some animations here. You can see we are correcting the equinus, so lifting the foot up here. Here we're correcting the rotation of the foot. And then here you can see we're correcting the varus angle of the foot. And this is all with maintaining the structural integrity of the surrounding foot and leg. And this is an animation. We took a patient's casting series and we animated it to see what all the different changes would be. So this is the same cast in 3 different views, and you can see what the direction of correction is here. So I wanted to talk about a small subset of results. So this is a subset of 9 patients who've had an isolated diagnosis of clubfoot, 6 males, 3 females, 2 to 1, just like we were talking about. 5 of them had unilateral clubfoot and 4 of them had bilateral clubfoot. So altogether, we collected 49 casts from them. All of these patients were less than 2 months old at treatment, and they all had an average DiMiglio score of 14, which is about a severe to a moderate problem. So what we did, we took a 3D scan of their first cast that they had, and then we also scanned their last cast. So we know what the first one and the last one look like. So based on all our models and all our patient data, we wanted to figure out, okay, if we showed this to a computer, can we make what the last model will look like? Can we predict that? And what will that look like? And so this is one of our results. So here visually, you can see that it's pretty accurate. We overall did a pretty good job in keeping the structural integrity of the rest of the leg and the foot, and the final foot position is in the same. And we were able to do this for every sub-step up until this one. So visually it looked great, but we also wanted to measure the angle. So this is a small subset of the simulations that we did for all these patients. And what we can see is when we measure the angle of Aquinas, we were able to match it to the real cast within 1 degree. And then the same thing when we were measuring the derotation, the correction of the derotation of the foot, when we compared the real cast to our simulated cast, we were able to match it within 1 degree. And then finally, we also wanted to look at the point cloud. So what a point cloud is, it's almost like the atoms of a 3-dimensional model. And the green one is actually the point cloud of the real cast, the real last cast. And then we overlay that with our simulated cast, which is in purple. And as you can see here, it actually overlaid very nicely. So what this shows us is that there's very high accuracy on our simulated models compared to what the orthopedic surgeon would place themselves. And we're able, these point clouds, the difference in the spatial differences is within 2 millimeters. As you can see here. So we've developed a reliable method to measure the complex 3-dimensional movements between serial clubfoot casts. And hopefully with this ability to calculate this, we will be able to generate computer models that can predict the optimal cast shape. And then no matter where you are in the world, somebody can 3D scan the original deformity, and hopefully we can help figure out how to get that child the treatment and the standard of care that they need. That's it. Thank you.
Push holding slide.
Wala si Sid.
Okay.
Thank you so much, Dr. Anu.
My pleasure.
Holding slide, please, Siddhant.
Can I share my screen?
Okay, so we'll wait for Dr. Junaid. Just wait,
Okay.
Dr.
And
Junaid.
now to introduce you. And then I will introduce Dr. Junaid.
Can you please share?
Thank you very much, Dr. Dayal, for this presentation. And it's now my honor and privilege to introduce the next speakers. As you noticed, there's a change in the program since Dr. Sajjad Rahman, he's not able to be with us for emergency situation. So the next speakers actually require no introduction. You've been listening to him and hearing from him for the last 10 years. And in the last 2 days, he's my friend and partner, Dr. Junaid Khan. Dr. Junaid Khan, as you know, is American Board Certified in Pediatrics. He's the head of neonatology in Al-Rahba Hospital. He's a member of AAP and Canadian Society of Pediatrics. He's gonna continue with the theme of quality and talking to us about using care bundle to improve healthcare quality in neonates. Please join me. Welcome, Dr. Junaid Khan.
Okay, thank you, Dr. Ayman. So, as Ayman said, that it is the quality session about. So I choose this topic at the 11th hour because Dr. Sajjad Rahman has some problem. He's not feeling well. I wish him full recovery. Uh, so the bundles of care, you heard about a lot of bundles, and what is the implications, what is the outcome for those bundles? So I will try to give you some review on that. I have nothing to disclose. So innovative approaches to improving care to the use of these bundles. I will try to give you some history from where it is started, theory of change, then how to design, what are the outcomes, reflection and suggestion for the further research. Now, learning together to improve care is the main theme nowadays. We cannot do individualized approach. So that's why we have to share our knowledge and our practices depending on the evidence base. So this is the stratification or the ladder model of that learn, then measure it, then improve, and then share with your experience. And this is the main model we are going to apply now or implement in our practices. So what is the improvement formula? The formula is simple: generalizable scientific evidence, then you have to choose the particular context according to your patient and practices, and then you have to perform improvement project or measure your performance. So what to do is evidence-based medicine, and how to do is evidence-based practice. So we will further elaborate on that. So this is the improvement formula nowadays implemented in many of the hospitals. It is published in 13 years ago by Dr. Betteldine and David Off. So what is the definition of bundle? What do you think, what do you mean by the bundle of the care, or what is the bundle? So it's a small set of evidence-based intervention for a defined patient segment population and a care setting that when implemented together will result in significantly better outcome than when implemented individually. So if you do any process individually, the outcome cannot be that robust or that good as if you try to do a combination of a few processes. So, and has to be targeted about some population or some patient segment. Now, some of the history that the first time the bundle was introduced by Institute of Healthcare Improvement in USA in collaboration with Voluntary Hospital Association, VHA. It's a joint initiative, and they want to idealize design of the ICUs. So of course the critical care is the critical care, and it has to be very focused treatment there. So they involved 13 hospitals, and the goal of the initiative was to improve the level of the critical care, the reliability of that, and then they measure the outcome. The theory was that enhancing the teamwork and communication, and they focus on the areas potential for the great harm and high cost, and where the evidence base was strong. So as you know, as the old Hippocratic oath, that first do no harm. So everything based on that uh, Hippocratic oath. The first two bundle designed and published by those two association is the central line bundle, which we call CLAPSI bundle, and the ventilator bundle, which we call the VAP, ventilator associated ammonia bundle. And you all know those components of those bundle. For example, hand hygiene in central line bundle, maximum barrier precaution, chlorhexidine, optimal catheter site selection, daily review of the line necessity, and so on and so forth. The measurement and the implementation of that bundle is going to be on the basis of all or none measurement. All or none means, as we learn from the physiology, either the muscle contract fully or the muscle will not contract. So this is the all or none process. So whatever the variables in your bundle, you have to implement all of them, unless and until some medical contraindication to that. So again, this is the same formula, generalized scientific evidence, particular context according to your patient, and then you have to improve your the by measuring your performance. Initially, when they designed those bundles in IDICU, Idealized Design ICU initiative, they found it out that only 10 to 20% compliance at the best. So increase to or to motivate to change processes, it takes some time, and it is really very important to understand that these type of change really brings the good and excellent outcome. So how they initially did, they focus on the teamwork and the communication, and this is the another great topic on talk about the teamwork and communication. But for this talk, I just want to mention about or emphasize on that of course the teamwork and the communication is the main thing to ensure the great outcomes of the patient. So the focus on teamwork and communication in ensuring reliable and consistent care to improve the compliance rates ensured. So high level of compliance with the central line bundle decrease collapses. So what they find it out when they educate, when they get the permission of the team, and when they communicate it very nicely, then it is the high level of the compliance that they achieve, and they find it out that it is the rate of the collapse in that particular situation is reduced. And if I'm now currently attached with the Mayo Clinic, they all also have the 5 safe behavior in under the umbrella of first do no harm. And one of them is the proper communication, proper handover, and proper teamwork. So what is the element of the success? First, in both cases, participating clinicians should agree, the all other teams should agree, and it should implement it accordingly. And the second is the list of elements included in the bundle was short, no, not more than 5. So the reason is that if you have a guidelines of pages and pages of 17 page, 18 page, nobody is going to read it when the frontliners or the doctors or the physician or the nurses want to use them. So it has to be concise. So that's why the idea of algorithms comes, idea of pathways come, that in this time you have to do that much treatment or that in a very short and nice way. So this bundle should not include more than 5 steps. Of course, the message, what we are trying to learn, that bundles are not intended to comprehensive care when the compliance is a measure for a core set of accepted elements of the care for clinical process. And the most importantly, the necessary teamwork and cooperation required will result in the high level of sustained performance, not observed when working to improve individual elements. And this is a very important message learned from this exercise. Now, there's some data from 2018 in article of critical care and shock presented ventilator bundle compliance report from a neurosurgical intensive care unit, and you can imagine the acuity of that unit, neurosurgical intensive care unit, is very, very high. And what they find it out, the pre-educational compliance and the post-educational compliance. And what they conclude that a simple education strategy can improve compliance of the ventilator bundle. This in turn, and although not demonstrate, can subsequently affect the mortality of the patient. Collaborative work between team members of the unit is the key of the compliance. So all the p-values are in favor of those after the post-educational compliance, the compliance increase. And as you know, as I said in my previous slide, if the compliance increase, the chances of the outcome towards better is very, very high. So theory of the change, why do bundle produce better outcomes? Bundle change the assumptions that evidence-based care is being delivered reliably. Reliable means that if you are doing some test repeatedly, it should show the same result. So it means that that test is reliable for that particular variable which you are doing for. So reliability is a very important issue. Then bundle promotes awareness that entire care team must work together, and it is very important. So for example, if you are at your senior level, at the high at the professor level, you are doing the rounds, you might have some different management than in the afternoon when the fellows are out, in the night when the residents are taking over. So to combine the efforts and to make a standardized approach to the patient is a very important aspect of that. Bundle promotes the use of improvement methods to redesign care processes. So one by one, if you take it, so bundle changes the assumption that evidence-based care is being delivered reliably. So if you have 5 elements and let's say 90% reliability is there, then the 5 times 90%, which is a very high reliability on that. And typically most clinicians assume that the bundle elements are being reliable perform on their patients. However, when they collect their initial data, they are often surprised at the low level of all or none bundle compliance, with some ICU findings reliability levels of 10 to 20%. So that's the issue of the compliance, that if you comply to that, your bundle of care, your results will be very good. Then bundle promote the awareness that the entire care team must work together. So as I said, teams that have achieved high levels of compliance and concomitant improve outcome did so through working as a team in new ways. So using specific daily goals developed by the team and the patient, multidisciplinary round, debriefs, handoffs at the end of the day to reflect on compliance and to plan ongoing improvement. The third one is bundle promote the use of improvement method to redesign care process. And there are other model for improvements, like for example, what are we trying to accomplish? How will we know the change in the improvement, and what change can we make that will result in improvement? And then we do PDSA, the plan, do, study, act. So the theoretical step in developing a care bundle, it identifies the critical care theme. So whatever the critical or acute things happening in your unit, you should identify that. Then identify a cluster of intervention practices within the theme. So you must doing something individually. If you combine all these together, that's a much better approach to, or much standardized approach to the patient. Then, of course, you'll search the literature. After searching, I always said the research the literature, then categorize the available research according to its quality, and delete any intervention practices from your list that do not have an adequate evidence. On the basis of analyze research evidence, develop evidence-based intervention. So that's how you will reach the excellence of care in your unit. So how you can design a bundle? So this is the bundle design guidelines. The bundle has 3 to 5 interventions. Each bundle element is relatively independent. The bundle is used with a defined patient population. Multidisciplinary care team develops the bundle. Bundle element should be descriptive rather than perspective to allow for a local customization, and compliance when the bundle is measured using all or none measurement with the goal to, to touch about 95%. So the first element, the bundle has 3 to 5 intervention with a strong clinical agreement. So it is already recommended that they are generally accepted in national guidelines and by local consensus of clinicians as being appropriate care for the population of the focus. So the goal of the bundle approach is to pull together those 5 elements and to apply when they need it. And it can include only those elements that most clinicians accept applicably to most patients in the populations, allow the team to move forward with improvement rather than spend time debating the validity of the elements. If you have more than 5 or 6 elements, it becomes mathematically more difficult to achieve high compliance with all or none measure. So it is recommended that when you develop any bundle, just limit it to 3 to 5 interventions. Since the intent is neither to create a comprehensive care protocol nor to include elements that vary in the applicability to individual patient, using 3 to 5 element is most successful. The second is each bundle element is relatively independent. So the bundle is designed so that if one of the element cannot be implemented for some reason, it will not affect the whole 5 steps. So for example, in the center line bundle, if the center line insertion site was not cleansed with the chlorhexidine due to any reason, the remaining 4 center line bundle elements should be implemented. So it has to be individualized. The bundle is used with the defined patient population. So of course, the population you are using, so we are working in NICU with a very premature baby, so our population is different. In the surgical unit, that's different in the PICU or the any other adult ICU. So we have to design the bundles in consideration of our population, which is very young and newborns and most of the times the premature babies. Of course, this is the key that the multidisciplinary care team develops the bundle, and communication and communication and communication among all participants and all stakeholders should be essential. The bundle elements should be descriptive rather than prescriptive, and I told you why. So we put the one example that you should just put it, for example, the DVT and the peptic ulcer disease prophylaxis element. You just put this element. You don't have to specify which medicine or which this thing they can be do accordingly. So for example, if you want to have a neonatal sepsis bundle, we cannot suggest any antibiotics because each NICU bacteria level is different. So if I working in a mid-income countries where the gram-negative is very common as compared to, so I cannot suggest the same kind of antibiotics to those units. Local clinician will determine the appropriate form of their patient population, so they know their patient population very well and they can modify it. All exceptions should be documented. This is very important. So we just heard Dr. Hussam talking about the importance of medical records, electronic medical records. So any deviation from the standards which you make for your own unit, if you deviate from that, you should document that why it is a document. So the person who's taking over in the evening, in the night, they know that that's why they deviate from their standard of cares. Now, the compliance with the bundles measured using all-around measurement with a goal of 95% is not that easy. But if you do the proper education and proper training for that, you can. The compliance with bundle is measured by documentation adherence. There is a simple checklist, yes or no, you can mark it on, and then you can do it. As I said before, there is no partial credit is given. If it is something missing for no reason, then it is not completed as a bundle care. The percentage of all or non-compliance for a bundle always focuses on a patient population. Example, the percentage of patients on ventilators in the ICU who receive bundle elements or had documentation contraindication. So the compliance is very important. Now, this is the example of the compliance is from the Center of Disease Control and Prevention National Health Safety Network. In 2019, 2018, they published it. Look at these two lines. So the first line, which is, I don't know which color you are seeing, but in my screen it's a blue, which is the which is the ventilator-associated pneumonia VAP rate, and the green, which is the VAP bundle compliance. So as you can see, forgot about the variable, I come to that, but as you can see, the use of the bundle increase, the incidence rate of the VAP is coming down. Of course, there is some spikes, but look at that. It is very positive correlation between two. Now, if you see that web bundle started here, then implementation of that, and then minimum of 10 patients audited each month. And as so long as they are auditing and their compliance is good, is increasing, the rate of the VAT is decreasing. So it's a very positive correlation. To make it easy and very simple, this is the total bundle compliance, and this is the number of the VAPs. So in January 2012 is zero VAP when there is a 90% compliance. There's a 94% compliance, but they have a one VAP. It can be possible. But look at that. When they drop to 88, the VAP increased to the 3 in that National Health Safety Network. So it is a positive correlation between the implementation of the bundles and the compliance. Again, in 2018, International Journal of Applied Research also published that the practice score was classified as adequate and inadequate practices. It was observed that care bundle adequate practice was 85% and inadequate practice was 15%. And they found it out that in conclusion, compliance with the standard of the care bundles was relatively acceptable. So the compliance, the people want to comply with that bundle. There's another study in May 2019. This is the change in the crude mortality, then change in the length of stay, and preoperative antibiotic use. And as you can see, in all parameters, it is really a drop in those variables when they apply the standard of care and the bundle of the care. So the significant improvement in recognized quality standard of care were achieved by using the evidence-based care bundles. So it is really very evident now that if you imply or if you have compliant with your bundles, you can have a very good outcome. Overall, it is published in 2019 in Implementation Science, the effect of care bundles on patient outcome, a systematic review and meta-analysis. You cannot see is a very busy slide. A lot of studies all go in the favor of the care bundle as compared to the favors of usual care. So all in the favor of it, make it easy. I divided it into the different variables, but as you can see, all the diamonds in favor of the bundle of the care. Now, it is very important. Nurses is the most important integral part of our healthcare system. And this is the published in again 2019 in International Emergency Nursing. And they want to find it out the nurses' perceptions of using an evidence-based care bundle for initial emergency nursing management of patients with severe traumatic brain injury. Again, the acuity is very high. It's emergency nurses with a severe traumatic brain injury. They are receiving the patient. It is this study done in the Thailand, and what they found it out that Thai emergency nurses perceived that using the care bundle helped them to improve the quality of care as a result of increased knowledge, skill, and confidence. A care bundle approach is an acceptable strategy to increase integration of research evidence into the context and facilitate emergency nurses to deliver optimum care to the patient. So this is one of the example, but I think it is fit to all in intensive care in NICUs where we have a very sick population of the patients. So to finish with off, back to the start, J.L. Vincent said one size most certainly does not fit all. So why bother to have a guidelines and a standardized approach and bundles? It is not true because they work. As I showed you the evidence, as I showed you the studies that the bundle of the cares is work because they have been shown to work in terms of improved outcome. So, but for the reason outlined at the stage, at the start, improve multidisciplinary care, better, more efficient team working, and realization that the problem is exists. Care bundles are an excellent idea and should be our aim to ensure all our patients are managed appropriately and aggressively, reducing organ failure, reducing mortality, especially if you are working in the intensive care environment. No care bundle for an area as a diverse as sepsis management will ever be perfect, creating a set of broadly applicable intervention to consider in all patients all the time is very, very important. So a bundle can bring together these ideas, crystallize them into a small set of bullets, allow wide dissemination to allow those caring for a defined patient group, allow realization that intervention early will improve mortality. So as you know, in our field, the golden hour, the golden minute. So if you have the bundle of the care that you have to provide antibiotic within 1 hour, you have to complete that set of the problem in that certain time, it definitely improve your outcome in terms of morbidity and mortality. In my previous workplace, we implemented the bundle of the care of IVH, and we get a very good results. I'm collecting on it. The data is still, and we will publish it. Establish and reinforce application of the best practice. So my take-home message: these to ensure optimal support from the clinician, bundle developer should always remember to select elements that are supported by the evidence. It is worth reiterating that a bundle itself does not improve care. Rather, improvement is a result of the strategy taken by the team to redesign, work, communicate better, and work more effectively towards achieving patient goals. It is important for future bundle to be tested since not all clinical topics lend themselves to this approach. Remember, I told you the old Hippocratic oath, first do no harm, but there is a new oath also, and they said that I will apply for the benefit of the sick. All measures are required, avoiding those twin traps of overtreatment and therapeutic nihilism. So the meaning of that, sometimes we are thinking that, oh, we are doing very good to the patient. In fact, not. We are overtreating it. And therapeutic nihilism means that our false beliefs about some kind of a treatment. For example, yesterday we discussed about how that we are prolonging the antibiotic treatment more than 7 days and 10 days. And all the evidence suggests now that it is not needed. So this is the new Hippocratic oath. You should combine with the first do no harm. My last slide to remind you the same quote, medicine is the marriage of science and art. What you know is the science, and all of you are much more knowledgeable, but how you apply it reliably and effectively is an art. And we shouldn't broke this marriage of science and art. With that, I will close my talk. Thank you very much.
Thank you, Dr. Junaid. Thank you, everybody, all the excellent speakers for their great presentations. Now we're going to have a panel discussion. We have a lot of questions coming our way, and we keep receiving questions as we go into the interactive session of question and answers. The first question will be for Dr. Hussam. Dr. Hussam, we have a question about electronic documentation is more time consuming than paper documentation, which lead to less time spent in patient interaction with patients. How can we balance this with the benefits of electronic documentation?
Yeah, so thank you so much for the question, Simon, and for the asking party. So the clinical documentation is very, very wide topic. We can talk about it for hours and hours. However, this was my favorite topic to deal with. The physician documentation in particular needs a lot of standardization. We know for a fact that worldwide, the standardization for physician documentation did not exist for years and years. And this has led to a lot of confusion with the data and the document retrieval. Again, go with that paradigm, garbage in, garbage out. I'm sorry, but the thing is, we invest a lot of time to document something is not agreed upon as standards to be used, and we may opt also to make use of the free text, the copy-paste functionality of the clinical documentation, physician documentation in particular. This has led to a lot of confusion. So the short answer, because of lack of standardization with the physician documentation, this might be one of the end results, and the dissatisfaction of physicians with this, with the way we do documents in the electronic health trackers. So I would say having a couple of standardized templates would greatly help. So some of them are disease-oriented, some of them the service-oriented, procedure-oriented, this kind of thing.
Great, thank you very much, Dr. Sam. The next question for Dr. Dayal. We have actually a lot of questions for you, but I will just try to break them down. When to start the treatment for clubfoot, and how early can we start the treatment or recognizing the problem in a premature infant of a clubfoot in a premature infant?
Yeah, those are great questions. So the ideal time to start treatment for clubfoot is actually when the infant is less than 2 months old. And that's because their foot is very supple, their bones haven't ossified yet, and it's more easy to pliable to move the different positions. And then actually for the second question is sometimes you can actually notice this in utero on in ultrasounds. So it's a great way to at least discuss this with the parents on what to expect when coming out. Sometimes you notice it on a prenatal ultrasound and then in reality the foot is fine. There are other times when just from being in the womb and squished, the foot looks like it is a club foot, but if you can move it back, then it's totally normal. The biggest thing is after they're born, if it's stuck in this position, then that's considered a club foot, and to seek treatment as soon as possible.
Very good, thank you.
Thank you.
Next question, Dr. Junaid.
Yes.
How we should enforce bundle in the real time, not into retrospective audit? How do we have somebody who watch and can stop the procedure if we violate the bundle, or should we just do retrospective audit?
That is actually a very good question and a little bit difficult on it. It depends on the emergency you are. As I showed you one study from the Thailand where they received the brain injury patient, and all of them, the nurse's perspective is that they can apply those bundles right away, and it's not any problem. So I think that it needs more education and the teamwork. It's like a pause that one is the course, one is the team leader, and then you are running the code. So it's or the NRB. So it's like that if you have a complete checklist, and if you know the bundle of care you have to apply, you can do that. For example, we had in my previous hospital is the IVH bundle of the care. So as soon as 24-25 weeks are born, we started from that. It includes like dimming of the lights and the sound protection and all those things, and to put it in the straight line head and something like that. So we started from that point. Yes, sometimes you are not that accurate, but that's how we said that if you implemented 90% compliant with the bundle, you are doing okay.
Very good, thank you. Dr. Hussam, you listed a lot of advantages to using electronic medical records. Can you list some of the disadvantages of using electronic health informatics?
Of course. Actually, this one I deleted.
This is not from me. This is from the audience.
No, I like the point because I deleted deliberately the couple of slides from the presentation talking about those risks and pitfalls. So certainly this would medication errors, and we come across it in every day, that medication errors because of the while ordering. So again, some of them are user tech as a lack of proper training. Another would be system design issues, and the defaulting medications, doses, routes, etc. These kind of things. And so the other thing is the copy paste, which is we all know that functionality and how bad this might end up having. I remember one of the cases I came across was like one of the documentation was a baby in critical condition, NPO, exam normal, feeding well, and for the charge. This was because of copy paste functionality, and we all know it's worldwide. It's not something. So unless we pay a lot of attention, again, I'll go back to the point of the system design or the target benefits first. This would be translated into a couple of targeted benefits at the organization, facility, service, etc. And because of that, some standardization, and again, the proper training for all the practitioners, this would lead definitely to minimizing those kind of risks, which is very, very, very important. So thank you for the question.
Okay. Thank you, Dr. Hussam. So next question actually is very technical. I'm sure I'm going to say the name of the participant who asked it because I think he is an orthopedic surgeon, Dr. Sabir Khan Khaybar from Teaching Hospital, Peshawar, Pakistan. I know Dr. Junaid, ring a bell.
Yeah.
So this is for Dr. Dayal. Till what age Ponseti method is recommended, and beyond which age surgical method is
The question is, Dr. Ayman is, I think the sound is a problem. So Dr. Dayal, the question is that...
we broke up. This is for Dr. Dayal. Can you hear us?
Can you repeat it again, Ayman?
Okay, so the question, Dr. Dayal, till what age Ponseti method is recommended, and beyond which age surgical method is recommended?
Yeah, that's a great question. So I think, the Ponseti method is recommended as soon as possible, but there are in some countries where they have attempted to do the Ponseti method, when children are greater than 1 year old. It's more likely the longer you wait to get treatment, the more likely you'll need a surgical technique because it's very hard to manipulate the foot and the bones and the tendons are already set. So it's a difficult question.
Okay. Next question also for Dr. Dayal. I don't know if you can hear me okay, because we are kind of breaking up a little bit. So the question is, after completion of weekly serial plasters casting, which type of shoes or braces and physical exercise do you recommend, and for how long you maintain and further improve the correct position?
That's a great question. This is actually very central to clubfoot treatment. So the serial casting is almost 2 months. And then what happens after that is we place the child in shoes that set the foot, that keep it set there. And it's attached to both feet. And they wear this bar almost 24 hours a day up until they're 2 years old. And the reason we do that is so there isn't any relapse or recurrence of the clubfoot. So there are many different types of bars out there, and there are some very low cost ones as well that are very helpful in global health situations. And that's actually the key, is to make sure that the parents keep them in that position for up to 2 years old.
Okay, great, thank you. Next question, Dr. Hussam. We know that, when we have data designed for all ages, it makes sometimes customization of data for specific ages or certain diseases difficult. What's your recommendation of how we customize the data for its use for the neonatal population, not for the general hospital population?
Right. So again, the systems are quite smart, and you can categorize data according to the age group. This depends on the data model and registry and the data repository you design first place while designing the system in. So it depends, again, what sort of organizations. Again, those kind of decisions are at the organization level, not facility level. Because at the end of the day, just I'll take the example of SEHA, for example, that we need to know what's happening at the neonatal service across different SEHA facilities. So there must be some sort of design decisions taken at the organization level to make that categorization of data. If I'm aiming that first place before and at the design phase of the system implementation.
Great. Thank you very much. And thank you for all the speakers for great presentations and great sessions. We're gonna have some more questions. I'm sure they're coming through, and we will send them to you as they come through. So hopefully we have your email so we can send it to you. So I appreciate your time, and thank you very much for being with us. I appreciate everybody's time, and thank you very much. That will conclude the session for the morning.
So I have questions. Remember with the presentation I had about the which system, whether the system are vendor specific or vendor neutral, and the other one, what is the best system to adopt. So I'm not sure if anyone was, shared the answers of those questions, but probably for sake of time. So those kind of system, the best system is that system comply with my needs. This is the best system ever. So it's not something towards any of the vendors. The second thing, the transformation process is vendor neutral. So a lot of vendors keep saying, we provide whatever training because this is important for you. The best system is my system that fulfills my requirement and it's vendor neutral. So thank you again, and very much appreciate it.
So
Great.
thank you very much. Thank you, Dr. Ayman. The next session will start in 15 minutes. To all the participants who join, it's a session, very comprehensive session on neonatal endocrinology from the Children's Hospital of Philadelphia. So if you have time, join. And you don't have any option, Dr. Ayman, you have to join. Okay, thank you.
I'm not going anywhere. Thank you very much, everybody.
Thank you very much.
Thank you. We
Thank
take a break for 15 minutes and we'll come back. Thank you.
Thank you so much.